Hello, everybody, and thank you for tuning in to the first webinar of our Parkinson's Awareness Month series. We usually do this in a large gathering over a few hours, and it's one of my most favorite days of the year. So while I know it's not the same, I do hope that you find this virtual program just as beneficial to get your questions answered and learn a little bit something about Parkinson's disease. So for those that know me and those that don't, my name is Dr. Jill Farmer. I am the director of the Parkinson's Disease and Movement Disorder Program at Global Neuroscience Institute. And I'm in my office today because I had a research patient this morning. So we'll be talking a little bit about that in today's discussion. My kids are on spring break and they're also here in an exam room watching a movie. So I told them not to pop in and out, but if you do hear a little scurry next to me, that might be who it is. But just a little bit about what to expect today and over the next few weeks. Webinars are not new to anybody at this point. We've been doing them during the course of the pandemic, but we would like to have them be as interactive as possible. And so if you do have questions, please type them into the chat box or the Q&A. I may not be able to see it while I am talking, but I will address them at the end of the presentation. The presentation is set for an hour from 12 to 1, so we'll try to be mindful of everyone's time. And then if there are more questions that we just don't get to, we have a whole session dedicated just to Q&A at the end of the month. So you can watch everything, take it in, learn some stuff, and then whatever you have questions about, we can go over that also at the end of the month. So if we don't get to it today, know that there are other ample opportunities. And the agenda for the month is 5 separate talks. So today we're going to be talking a little bit about what's in the pipeline for Parkinson's disease, what's new and up and coming. Next Friday, we're going to have a panel discussion with Dr. Atom Sarkar, who is the functional neurosurgeon with Global Neuroscience Institute, who does our DBS surgeries, and with Dr. Zafar Samir, who is a gastroenterologist who will be talking about the procedure Duopa. So next week, we'll be focusing on the surgical management of Parkinson's disease. The week after that will be kind of an experiment. So that will be the only event that won't be in a webinar format. That will be more like a Zoom meeting. And that means that we'll see your faces, you'll have the ability to interact. And we're trying to position it almost like speed dating for Parkinson's information. What we'll do is we have a number of sponsors, which you've seen on this scroll. And we also have access to advocacy groups and just resources in the community dedicated to Parkinson's disease. So we're going to break out into separate rooms. And you will stay in your breakout room, and then the different exhibitors will rotate through. We'll figure out how many people are on that day and how much time we need, but think about somewhere between 5 and 10 minutes per exhibitor. So you'll be able to hear from them, you'll be able to learn what they have to offer, and especially for the pharmaceutical sponsors that are on, if you have questions about their meds, about access, about coverage, things like that, that will be your opportunity to talk to them. There'll be a couple of moving parts that day. So like I said, it'll be a little bit of an experiment, but I think we'll be able to get it to work. And I think it'll be a fun afternoon. After that, we'll have another panel discussion talking about the multidisciplinary clinic with Dr. Catherine Lester, who's one of our neuropsychologists, as well as the rehab services from Robert Wood Johnson to talk about what they have to offer: physical therapy, speech therapy, occupational therapy, and the like, and the true collaborative effort it takes to manage Parkinson's disease. And then the last Friday of the month, like I said, will be our Q&A session with myself and Dr. Sarkar. So if you have questions that come up during the individual sessions that either hadn't been addressed or you didn't think about until after the fact, that will be an opportunity for you to ask them. We're also collecting them during the course of the month. So if you reply to the email that you got, the movement@gnineuro.org, and submit your questions there, we'll also catalog those as well as live questions during the course of that last session so that we can hopefully get to everyone's concerns. So that was just a little bit of housekeeping. And now we'll get started with the talk today. So I'm just going to switch. And different loop I need. Just give me 1 second. Here we go. Before I share, I see one question that was in the Q&A. Let's see. Oh, just Javier saying good morning. Thanks, Javier. Good morning to you as well. So, share. And play from start. And here we go. Okay, so today we're going to talk about updates and overview and what's in the pipeline. Many of you have heard me give an overview of Parkinson's management talk, so I wanted to be mindful of that, and I didn't want to necessarily go through everything again. So what we'll be talking about today is really the newest meds that have come to market over the past year, and then some of the drug delivery systems that are in phase 3 trials now, which mean that they're getting closer to actual clinical use. And there's always the questions about the therapies that are a little further down the road in development, but still exciting because those are the potential for advanced therapies, disease-modifying therapies, things like that. So, and then we'll talk about some of the advancements that have come with the surgical management for Parkinson's disease. So here's the meds that many have heard me speak about before. And when it comes to neurologic conditions, Parkinson's disease does have quite a lot of therapies that are available for it. But even with all of this at our disposal, we know that it's not complete. Many of these medications focus on dopamine. Many of the dopaminergic medications focus on movement, the tremor, the slowness, the stiffness, things like that. And anybody who's listening in or watching this later knows that there is more than movement that impacts Parkinson's disease. So while we have a good arsenal at our disposal, it's still incomplete. And what all of these medicines have tried to do with their evolution is to mimic the way dopamine works in the body. So it wants to be a nice, steady state, so you have good, consistent symptomatic control. And what the newest meds that are available are really focusing on is when that control drops off. So it's the off phenomena. And I know many of you have probably logged into multiple online seminars, and the theme du jour has been, what is off period? What does that mean? And we'll talk a little bit about that because that's what the newest medications have been focusing on. So what is off? Off is really a return of motor and non-motor symptoms. So we typically think of this in the context of carbidopa levodopa because that is a medication that we know you have to take multiple times a day. And oftentimes we'll guess when we're talking to patients, we'll ask the question, well, do you feel an improvement when you take this medicine? Some people do, some people don't. If you do feel an improvement, you can tell when the medicine kicks in, we say that's on. Now, the next question is, well, can you tell when the medicine starts to wear off or your symptoms return? And that's the off phenomena. And that can come in multiple different ways during the course of someone's day. It can be a delayed time for the medicines to turn on, to kick in. So that's considered a delayed on, which is a type of off. The dose can fail completely or be completely ineffective, and that's a failed dose, which is a type of off, and that can be unpredictable, and you don't know how or when that's going to happen. Or, and this is probably the most common one, do your symptoms return before your next dose? And that is the wearing off phenomena. And that's why medicines have to be dosed so frequently throughout the day, because we know they only last in the system a short amount of time. Carbidopa levodopa, the general carbidopa levodopa, regular old Sinemet, really only gives a good symptomatic benefit for about 4 hours, which is why that's how we dose it. Early on in the course of the disease, you can get a larger window of opportunity. You may eke it out to 6 or even 8 hours, but that's not the norm. The norm is about 4 hours. And the reason why that change occurs is not because you've habituated to the medicine or gotten used to it or developed a tolerance or anything like that. It has to do with real estate. And this will come up a little bit more as we go through the new medicines that are available. The way carbidopa levodopa works is it works by bringing levodopa up into the brain and then converting that levodopa to dopamine. That conversion happens in the same nerves that make dopamine, the same neurons that make dopamine. When that area of the brain becomes more diminished as Parkinson's disease progresses, you have less and less of that real estate to do that conversion appropriately and effectively. And that's why there's more than one medicine in Parkinson's to try and get to that improvement in the level of dopamine. You try to mimic the way that it works, and that's with dopamine agonists, things like Nupro and Requip or Mirapex, ropinirole, or pramipexole. And we'll talk about some of the newer dopamine agonists now and their newer formulations, things like Kinmobi and Apokyn. And then you try to recycle it, and you can recycle it by preventing its breakdown, because things get broken down naturally in the body so they don't build up. So you block that process of breaking it down in the brain with medicines like rasagiline, selegiline, Xadago, sulfonamide, or you can prevent its breakdown in the gut. And those are medicines like antacapone or the newer formulation called opicapone. So there's different ways to try and get to it. But there's also medicines now that don't just work on dopamine, because we know that there are more chemicals at play in Parkinson's than dopamine alone, even though that's the one that got most of the fanfare when it was discovered back in the 1960s. So let's talk about some of the new medicines that are available. This medication, Nori Ants, some of you may be familiar with, some of you may not. It is the newest novel mechanism that we have to manage Parkinson's disease, because it doesn't work on dopamine, it works on adenosine. Adenosine is another chemical at play in the brain. And there is a seesaw of chemicals in the brain that have to be in balance in order for you to be able to move effectively and fluidly. And part of that balance is dopamine and adenosine. And what adenosine does is it inhibits the indirect pathway. Part of that seesaw are two pathways. One is the direct pathway. That pathway promotes movement, and dopamine stimulates that pathway. So when you have a lot of dopamine, that pathway, whether it's through dopamine your brain is making naturally or dopamine that you're getting through the conversion of levodopa to dopamine, it's stimulating the direct pathway and it is helping to promote movement. Dopamine also works on the indirect pathway by inhibiting it. So it has a process of keeping that balance together by promoting movement and inhibiting the thing that inhibits movement. So it inhibits an inhibitor because the indirect pathway works by keeping things slow and stiff. By inhibiting that indirect pathway, you can also complement the direct pathway and promote movement. And what adenosine does is adenosine works on the indirect pathway to promote it. So as Parkinson's progresses, there's a little bit more of this adenosine, which shifts the balance because there's a little less dopamine. And if you are having more of the thing that promotes the pathway that inhibits movement, you can see how that's going to have a negative impact on your ability to move. So think of it as a gas and a brake. Dopamine is like stepping on the gas pedal, and adenosine is like pulling up the brake. And this is from the Nori Ants website. So you can go and take a look. It's got some nice graphics. It's got some nice videos. And what we're trying to do is essentially release the brake by inhibiting an inhibitor. So what Nori Ants does is it inhibits adenosine's response to the indirect pathway. And getting back to that idea of real estate, some of you may or may not have had a test called a DAT scan when you were diagnosed with Parkinson's. It depends on how long you've been diagnosed and how obvious your symptoms were. Not everybody needs a DAT scan to get diagnosed with Parkinson's disease. It's still a clinical diagnosis. If we can see on exam that there's tremor, that there's slowness, that there's stiffness, and that there are some postural concerns. You only need 3 of those 4 things for us to have a clinical suspicion of Parkinson's disease and to make a diagnosis. If your symptoms are not that obvious, or if you were diagnosed with Parkinson's more than, say, 10 years ago, chances are you didn't have a DAT scan at that time, so it's not something that you used. If your symptoms are not that obvious, sometimes a DAT scan is used to help us determine, are we dealing with early mild Parkinson's disease? But if your symptoms are obvious, you really don't need it. This is what a DAT scan looks like, but this is actually not a DAT scan. A DAT scan looks at how well the brain uses dopamine. So it's a test of metabolism. So it's going to have these light up bright pictures. The things that are lit on these 2 scans is the basal ganglia. That's the area of the brain that really is most impacted by Parkinson's disease. But what this scan is actually looking at is the density of adenosine. So while there would be less dopamine that is seen over time in Parkinson's disease, you'll have more adenosine that is seen in Parkinson's disease. So that gets to that idea of real estate. So we're utilizing what a Parkinson's brain has to our advantage to try and manage the symptoms, which is why it is a medication that is a nice addition to dopaminergic meds to help with off times and slowness and stiffness. Tremor, it mostly works on the indirect pathway, so it's more of those slowness and stiffness types of symptoms, the bradykinesia, the rigidity. It may or may not have as much of an impact on tremor as the dopaminergic meds do, but it's still something that can be complemented to the dopaminergic meds. Which is another reason why this medicine has to be taken in combination with carbidopa, levodopa in order to elicit its best effect. So it's not a medicine that you can use by itself. Typically, it's a medicine that is used in combination with the other Parkinson's medicines that you may be taking. So the next newest medicine that is helpful for managing off times or those wearing off phenomena is a medicine called Gentis. And this is the newest version of the COMT inhibitors. COMT is an enzyme that works in the intestines, in your gut, that breaks down carbidopa levodopa, really levodopa, before it can cross over into the bloodstream to get brought up into the blood-brain barrier. Now, entacapone is the prior version of this medication. That needs to be taken with each dose of Sinemet, and it's part of a combined pill called Stalevo, which some of you may be using. This is a once-a-day version where it does not have to be taken with each dose of Sinemet. It can be taken first thing in the morning or last thing at night, and it works for the 24 hours to help with that inhibition of the breaking down in the gut so that more gets distributed so that it can exhibit an effect. And so what does that look like? So if you look at the gray line on the bottom, that's the up and down of carbidopa levodopa. If you look at the blue line on top, by adding a medication like on Gentis, you have a two times more increase in the availability of levodopa in order to be able to get into the bloodstream, to cross the blood-brain barrier, to exhibit an effect. And that density of improvement of levodopa absorption, because there's more available, is what can help with the wearing off phenomena that patients may experience with Parkinson's disease. So again, this is yet another medication that needs to be taken in combination with carbidopa levodopa. It can't be taken on its own because it won't have anything to work on if levodopa is not there. But the benefit is that there's more available so that it can get absorbed better and that it can exhibit a positive symptomatic effect. Now, with all of these medicines that help promote movement, you have to think, well, what could potentially happen if there's too much movement? So concerns for dyskinesia are things that we always discuss. Those are the extra movements like Michael J. Fox kind of. And if there are, other symptoms that you have sensitivities to with other dopamine medications, if your medicines make you a little sleepy, if your medications make you a little nauseous, if your medications may drop your blood pressure, because we're enhancing the effect of dopamine in this way, we have to also manage and watch to make sure that we're not exacerbating any of those symptoms. So nothing that is unusual in the things that we look for with other meds, but things, again, to be cognizant of, because whenever we're working on meds that act on the brain and whenever we're working on meds that can enhance movement, we want to make sure that we're not doing it to excess. So the last of the newest medicines is Kinmobi. Now, this is in a different category because this is not an oral medicine, and this is not a medicine that has to be taken every day the same way Nori Ants and on Gentis does. This is a medicine that can be used on demand. So some people will call it a rescue. It's not necessarily a rescue medication, but it's something that can be used if your symptoms return unexpectedly, or if you know predictably when you have some of those lulls throughout the day. So you might be able to use a medication like this that can help stem off that off from happening. It is a dopamine agonist. So in that same class of medicines like the Nupro patch and Mirapex, Pramipexole, Requip, Ropinirole, but it's not a pill form, it's a strip. It's not a Listerine strip, so it's not like you put it on your tongue and it just dissolves. It's a little bit hardier and thicker than that. It's a medication that has to go under the tongue and has to dissolve there for about 2 or so minutes. It's important that you don't swallow when you do that, because the purpose of this is to bypass the GI tract and get right into the bloodstream really quickly. And it does get into the bloodstream quickly. So in studies, this has been looked at that can, have patients achieve an on state, and that on state is compared to what their best on is with their regular oral medicine, so their carbidopa levodopa or variants thereof, so they know what it feels like when their meds are working. If this gets them to something as good as that or close to that, that's the marker, and it can do so within 20 to 30 minutes. Now, if your off states or your fluctuations are quicker than that, then that is something that you need to discuss with your doctor, because this may or may not be something that is appropriate. But usually when people feel themselves going into off, it lasts longer than just a few minutes. It lasts a considerable amount of time. So we have a video from their website that we can take a look at to see.
Kinase, apomorphine HCl sublingual film, is a prescription medicine used to treat short-term acute intermittent OFF episodes in people with Parkinson's disease, PD. You're about to hear from Lisa, a patient taking Kinase for use during her OFF times associated with Parkinson's disease. Her experience is unique and may not reflect the experiences of other PD patients. Please review the important safety information throughout and at the end of this video. Please see the full prescribing information, including patient information and instructions for use, at www.kinase.com.
Hi, my name is Lisa, and I live in Florida. My doctor prescribed Kinase for me for my OFF times. My OFF times are pretty dramatic. They happen several times a day. It starts down in my toes. My toes start to curl. My legs get stiff, and I start to lose my center of gravity, which is in my torso. It goes down towards my knees. So I'm starting to lose my balance. So you'll see me start to lean forward when I walk. Actually, what's happening here is my arm is getting very, very stiff, very stiff. And my tremor started in my shoulder, comes down. You can see my muscle is contracting here. So it's very, very uncomfortable. You can hear I become a little breathy because my chest becomes tight and my neck starts to get stiff in my head. It used to be that my OFF times would come on slowly. Now they kind of come on like a light switch. And if I'm in the middle of something that's very important, I can take the Kinase and it helps me get back to the on position. Kinase is a sublingual form of apomorphine that is a film that goes under your tongue. Kinase gets me on again.
Do not take Kinase if you are taking certain medicines to treat nausea called 5-HT3 antagonists, including ondansetron, granisetron, dolasetron, palonosetron, and alosetron. People taking ondansetron together with apomorphine, the active ingredient in Kinase, have had very low blood pressure and lost consciousness or blacked out.
So when I take Kinase, I follow the instructions for use and I drink some water so that the inside of my mouth does have some moisture in it. And I open the pouch and I take the film out and I put it under my tongue. And then I just let it work.
So they have accelerated the video in case you can't see it on the screen, because it can take up to 20 minutes to work. Sooner in some.
So this is how I look when after I've taken Kinase. I can move, which is awesome because you saw me leaning on the counter and I don't have to do that any longer because my balance has now moved up to my torso. So you can see I'm able to move. I find that I'm able to lift my feet up where prior to that I was shuffling my feet. I'm able to climb stairs. I'm able to have my balance back. I have control over my legs. Without Kinase, I would have to sit down until my regular Parkinson's medicines kicked in. And by taking Kinase, I recover and I'm able to get on with my day.
So the video is longer at the on their website, but it's very powerful to see. And I wanted to show it because I think it is something that needs to be known when you're trying to make decisions about medications. We could have an entire hour, multiple day discussion as to why this was chosen for this particular patient as opposed to other things, which is another thing I think that's important to look at with the video. As you can see, her speech was still a little bit impacted. Her tremor did not go away completely. And I think that's very accurate and very real world. This patient is not my patient. I don't know her. I wasn't part of the clinical trial that she was in. But she is somebody that, in addition to talking about these on-demand therapies or medicines to help with off time, I would also be having the discussion about DBS with her, because I think that her type of Parkinson's is the type of Parkinson's that would respond to neural stimulation positively. Tremor predominant Parkinson's, especially those that are now waxing and waning with their medication effectiveness, is absolutely the type of patient to have the discussion with DBS about. Some patients are not ready to consider it. Some patients might have other reasons why they can't do it, but as much as an on-demand therapy, as well as talking about adding on a daily medicine to help with her off times, are appropriate conversations, so is a surgical discussion. Kinmobi is not the only on-demand therapy there is. The original, if you will, the one that has been around the longest and still extremely effective, is Apokyn. And also, this is what their website is and what their homepage is. You can see an additional video similar to what you saw for Kinmobi on their website as well. The difference is this is an injection. So again, it's patient preference, it's ease of use, it's what is best available, but the underlying medication is both apomorphine for the both of them. The other on-demand therapy that is different is Inbrija, which is an inhaled levodopa. So again, there's also a video on their website that you can take a look at, but this is done through an inhaler, not an asthma inhaler. It looks more like a kazoo. It's a long inhaler, and it's a powdered form of levodopa that you take in through your lungs, again, bypasses the gut, gets into the system quickly so that it can help stave off an off period. The other thing that Lisa mentioned in the video, and it is true for all of these medications, is they do not replace the medicines that you're on. They are an adjunct to it. Whether you think of it as bridging from dose to dose, or whether you think of it as jump starting your day if you have off periods in the morning or a very predictable off time in the afternoon, you've already tried to, adjust your medicines, your oral medicines appropriately, and it's just not getting you that symptomatic benefit that you need. That's the conversation to have with your doctor about the addition of on-demand therapies. So meds in trial, there are subcutaneous continuous forms of levodopa under investigation. And that is what goes back to the very first thing that we talked about, where all of these meds and the evolution of meds really have not necessarily been to improve upon the chemistry. When they discovered levodopa, they discovered fake dopamine. So you can improve on that. It's just how to get it into the system more consistently. And what better way to be consistent than through a continuous infusion. So this is what the port site looks like for the subcutaneous, which means just under the skin, continuous infusion. This is then attached to a pump of varying sizes and degrees based on the company that is putting the device out. To give you an idea of what the AbbVie pump is like, because that's the study that I'm currently involved with, it's probably about the size of a large cell phone. So about this big, and about two of them stacked together. So not quite this thin, but just a little bit thicker than that. And it's often carried by either in a pouch or on a belt loop, or however it might be. And inside of that pump is a syringe of essentially what looks like water. It is thin, it's not thick, it's not viscous, it's a little bit sticky. And through that syringe, the pump slowly pushes the plunger down and infuses the medicine through this tiny tube that then just goes right under the skin. Neuroderm is the other company that is doing a very similar study with a similar distribution of medication. And I'm not sure what their device looks like, but on their website, if you go to neuroderm.com, they have a graphic schematic of it, and it might be a little bit different. But the goal is to wear these pumps for 24 hours so that you never have that peak and valley of medicine in the system. And these are both in phase 3 trials, which is the last phase before it comes to clinical market. So this is getting close. Patients that are using carbidopa-levodopa already and have had to increase their dose because of the different wearing off phenomena or lack of effectiveness may be considerations for the pump for subcutaneous infusion like this. If there are side effects because of tolerability of levodopa, because you need to take so much orally, by the time it gets to the gut to be absorbed, it's broken down. So it's causing excess dyskinesias, or it's causing ineffective dosing, or it's causing excess nausea. The subcutaneous infusion might be a way to better tolerate the levodopa, as opposed to having to take so much by mouth in order to elicit an effect. So this is the closest thing to the end of the pipeline. I think that it will be a very useful mechanism by which to manage the therapies. Practically speaking, there's always going to be questions of, it's still a device. Do people still want to wear it, even if it's a lot less cumbersome, a lot more user-friendly? And then what will the indication be for? Will it be for early Parkinson's or advanced Parkinson's, or whatever it might be? And that is arbitrary based on what can get approved. Any doctor will tell you most consistent dosing from early on will be the best for the brain and best for the symptoms. But could you start patients on the pump right out of the gate? Probably not. They're looking for indications for people who have already been on levodopa and are starting to experience those motor fluctuations. This is the current infusion that's available, and this is a therapy that I discuss with my patients. You can see it's a little bit more cumbersome than what's to come. But the thing about this is it's reversible. So if you are currently experiencing the wearing off phenomena and the taking lots of medicines throughout the day very frequently, every 3 hours, every 2 hours, but you respond well, and surgery, DBS surgery, is not something that's appealing or an option for you, this surgical procedure, maybe this device, it is done through a PEG-J, which is a tube that goes into the stomach but ends in the intestine, which you can see there because that's where the medicine is absorbed. So this does require a procedure, whereas the subcutaneous infusions do not. And this is not a clear liquid or a thin liquid. This is more of a gel. It's a bit thicker, it's a bit more viscous. So it takes a heftier pump to push it through. But as far as getting steady states of medicine in your system, it's fantastic. It is just something that, again, was a little bit of a learning curve and a little bit of a device getting used to phenomena that we've had with patients being interested in pursuing the Duopa pump. But this is what we're going to talk about next week, so I'll leave that there for now. So going on to the therapies that are further down the pipeline, not ready for clinical use just yet, but what everybody is always wondering about and hoping for. And those are the advanced therapies, or the disease-modifying therapies. And we always get questions about tyrosine kinase inhibitors. You might not know it by that name. You might know it by nilotinib, because that's the one that is currently in trials and is on all the blogs and the websites and Michael J. Fox and things like that. So we'll talk about that. We'll talk about immune therapy, and we'll talk about gene therapies. So we're always looking for neuroprotection. That is what the ultimate quest is for. And it's not a new quest. I mean, back in 2003, they did netpd, which is neuroprotective exploratory trials, which looked at 80 compounds that were identified. And by these compounds, these are things that were drugs that were already in use, or compounds that were known, that weren't new, but already in production, to see if they had therapeutic potential in Parkinson's disease for disease-modifying therapies. they went through them. They found some with potential for use, but they failed in the clinical studies. And what came to pass is not that the compounds themselves were ineffective or not helpful, but that the studies themselves were ineffective in being able to get the information that was needed. So this was an expensive hindsight, and it unfortunately soured the landscape to some degree as to being able to look at these therapies going forward and in the future. But as you'll see in the next coming slides, it's still a robust area of research. It's just taking a lot longer than anybody wants it to take. So the reason why they felt that it failed is lack of a biomarker. And biomarkers are things you can measure. And oftentimes we'll get the question, can you measure dopamine levels in the blood? And you can't. It's not an easy thing to measure. The closest thing we have to something that's measurable is the DAT scan that I was talking about before, because it looks at, well, the brain uses dopamine. But that scan by itself is not a way to measure just how severe the dopamine loss is. There are ways to do it. There are different analyses that can be done to the pictures, but in and of itself is not a staging technique or something that can measure the true loss of dopamine in the system. Can you measure it through cerebral spinal fluid? So there's fluid that bathes the brain and that the brain floats in your skull and comes around the spine and goes back up. The answer is yes, but it's not easy. So it's not something that is, part of clinical measurement that we would measure. It's really done more for research settings. And it's not even dopamine itself, but it's the metabolites and the breakdown of dopamine that might be what we are looking at and measuring. And the other thing is, these things have only focused on the motor symptoms of Parkinson's disease. It really hasn't done much to look at the entire picture of Parkinson's as a whole. So in order for these types of neuroprotective studies to be effective and give us the information that we need, we really have to look at biomarkers, and starting from there before we can even look at potential compounds. So the Lewy body is this potential biomarker that we might be able to manipulate in some way for these trials going forward. So you hear about Lewy body dementia, you hear about things that are on the Parkinson spectrum that have this pathology in it. This is really just an abnormal clump of protein. And this abnormal clump of protein mucks up the cells that make dopamine to a point where they can't release the dopamine anymore. And as we said, dopamine does get broken down, and it has two measurable compounds that we can look at through cerebral spinal fluid, HVA and DOPAC. Dopamine gets broken down everywhere in the body. So measuring some of them, if it's not in the brain, doesn't really help. But DOPAC is more specific for the dopamine that's broken down in the brain. So that is something that we can look at through cerebral spinal fluid. So we have a potential target to look at and a biomarker that may be measurable. So looking at alpha-synuclein as the target to modulate to see if we can then help change dopamine metabolism so that it doesn't clump and is able to be released. And then looking at the breakdown of that dopamine to see if we do something that inhibits alpha-synuclein, do we get more dopamine broken down, which means more dopamine is being released. So that's the idea. And the medicine that they have looked at that may work to utilize both of these this biomarker and this target is the tyrosine kinase inhibitor. And it's not new. Back in 2014, phase 1 studies, which are just feasibility studies to see if this is even something that's worth pursuing, said that it might be. And then it took another 4 or 5 years to do phase 2 studies, which is just the studies to see, is this something that's safe? Tyrosine kinase inhibitors are medications that are already being used for cancer therapies. And they work by inhibiting the growth of cancer cells. So can they utilize that same mechanism to inhibit the accumulation of alpha-synuclein in dopaminergic cells and then allow them to release more dopamine? So phase 3 studies are planned. So again, we're going from 2014 to now, and we're still not at the clinical phase of phase 3 studies just yet, but it's happening. There's also, if you are into looking at the research and you're into looking at the background behind some of these different investigations, there's of course some little heads bonking across different institutions, and some think that tyrosine kinase inhibitors, too much emphasis is put on them as a potential benefit, whereas others are saying, no, I think you're just studying it wrong. And the reason why you're not showing the same level of benefit is because you're not measuring things correctly. So it goes back to that biomarker question of, do we have something that's entirely objective that will be able to give us the information we need to see just how effective they are? All we can say right now is, as a compound itself, they are safe. And in the studies that have been done, there has been the allusion to that symptoms are improved in patients that get the medicine versus patients that do not. And when the medicine is stopped, there may be a return of symptoms. We can't say more than that. So no, I'm not suggesting anybody go out and buy nilotinib on the black market and try and use it. But I do think it is still something that has enough potential behind it that it's worth more investigation. So antibody therapy. So this is looking again at the target of alpha-synuclein, but these are only in phase 1 and phase 2 studies. So again, feasibility of potential, and are they safe for patients to possibly use? And Roche, Sanofi, AstraZeneca, AbbVie, Lundbeck, UCB, these are all companies that have antibody therapy studies in the early development stages of their pipeline. And what they're looking for is to see if they can create an antibody that can attack the clumping of the alpha-synuclein, will that prevent the clump from occurring and then allow the dopaminergic cells to function more normally? And it's great on paper, mechanistically. What they're seeing is that they're having some trouble with actually getting that antibody into the cell to do its job correctly, but they're still at the early phases where they can adjust and redesign to see what could become more beneficial and more effective before they enter a very costly and larger phase 3 study. So still actively being looked at as potential disease modifying therapy, but again, not something that is anywhere near clinical use just yet. And lastly, gene therapy. We get questions about gene therapy all the time. And again, these really are in the phase 2 study, phase 1 and phase 2 study pipeline. And the way this works is, it's a viral vector, which means that it takes a virus that has a very simple genome, that's where the gene therapy comes from, and uses that virus to bring new instructions into the cells that they're trying to target. Now, what's interesting about these is neither one of these gene therapies work on the dopamine cells specifically. So these gene therapies are not looking to make dopaminergic cells produce more dopamine. They're looking at secondary mechanisms to help improve the availability of dopamine in the system. So you would still be taking oral meds for these therapies. It's a complement to what the oral medications are already available. And that's a pretty big complement, because the way gene therapies work is it's either done through a surgical implantation, or it's done through an infusion. So these are not things that you can, just pop a pill and it would change it would get to the mechanism that it needs to do. So one of the gene therapies is looking at ways to make more of an inhibitory enzyme, to make more of an enzyme that will inhibit the inhibitory pathways, I should say, in the brain, like we were talking about before with the direct and indirect pathway. And another medication is a medicine that will help flesh out or improve the neurons in the brain that convert levodopa to dopamine, because those are lost over time, so that you might get a more robust and a more effective conversion from the oral medications that you're taking. And in a very recent article that my mentor, Dr. Fernando Pagan, just discussed these types of therapies in, he said gene therapies are still in the early development, and while scientifically plausible, they face many challenges regarding the stability of viral vectors, gene of interest expression, distribution, spread of the virus that's used, long-term expression, reversibility, adverse effect, and single versus multiple injections or surgeries. So again, these are things that are absolutely worthy of investigation, and it's wonderful that Neurocrine, ProSavin, Biomedica, Prevail Therapy, like 5 or 6, or if not more, companies are investing into these types of therapies, but it's still a ways away. But the fact that they are now actively engaged in this type of research is fantastic. So we'll finish up with advances in DBS. And we'll talk about DBS in much more detail next week, but this is just so you know, traditionally all DBS kind of is the same as far as there's a pulse generator in the chest, there's a lead that goes up to an electrode that's in a target in the brain. And for Parkinson's disease, that target is either the globus pallidus or the subthalamic nucleus. And we'll get into why some of those are, the different locations are chosen next week. But now there are 3 platforms available for use. And so we'll just introduce them today so that you know that they're available, and we'll talk more about them next week. So the first one we'll talk about is Boston Scientific.
Parkinson's disease symptoms, such as tremor, can have a debilitating effect on everyday life, from having a cup of coffee to signing your name. Parkinson's affects approximately over 10 million people worldwide. Deep brain stimulation, DBS, may help to manage symptoms which can't be effectively controlled by medication alone. It works by surgically implanting a modest medical device, typically under the skin in the chest, which sends signals to the brain via 1 or 2 insulated wires called leads. New advances in DBS technology, such as the Cartesia directional lead, are designed to allow your clinician to precisely stimulate a specific region of the brain. This helps to control your symptoms and avoid side effects. The treatment has received CE mark for use across Europe and elsewhere, and FDA approval for the United States. With Boston Scientific DBS systems, you can choose between a rechargeable Vercise Gevia or a non-rechargeable battery, the Vercise PC. Our deep brain stimulators are designed for patient comfort. They are thin and lightweight with smooth, rounded edges. Although not a cure, DBS is a well-established, safe, and effective treatment for Parkinson's, which can improve quality of life. So start picturing a life where you're more in control. Talk to your doctor about how deep brain stimulation could help you.
So, as I said, now there are 3 companies that have different platforms. I showed this one first because I thought it gave a nice overview of DBS to begin with, but it mentioned something that was particular to 2 of the companies, which is directional leads. So typically speaking, there are 4 areas of stimulation where you can affect a response. And the idea of directional leads is that in those 4 areas of stimulation, they can make even more targeted, narrow vectors of stimulation to try and help with tremor control or other symptom management, slowness, stiffness, rigidity, without exerting side effects by stimulating areas around it that might not need to be. Because as we've said, as you might have heard in either me talking about DBS or others talking about DBS, while it is an extremely effective and woefully underutilized therapy, it's not a be all and end all. And as with everything, there's things that you have to think about. So particularly speech, balance issues, stuff like that. And the idea that if you can target the area of stimulation a little bit better, you might have the potential to mitigate some of those other side effects. So the platform that has been around and been most established is Medtronic, and we'll talk about them last. But that is how Boston Scientific and this next platform that we're going to talk about, Abbott, distinguishes themselves a little bit from Medtronic because of this idea for the directionality of the leads. So the next is Abbott. Now, they also have the option for directionality in their leads, but they have just released information that they have the platform that allows you to adjust remotely. So during this pandemic, when we've switched over to telemedicine, the one thing that has been lacking is the ability to do things where you actually physically need to lay hands on. And DBS programming is one of those things where you physically need to be there to adjust the stimulation and look at the device. Now, Abbott is the only platform that has the ability to do remote programming so that if there are DBS adjustments that need to be made, you can do them while the patient is at their home and the doctor is somewhere else, at their office or at their home or wherever it might be. So we'll talk a little, play their recent development.
Neurosphere Digital Care allows you to go beyond the status quo, to break boundaries and transform care for people with chronic pain and movement disorders, and provides powerful, intuitive tools that enhance therapy management. Starting with Abbott's latest advancement in patient-centric neuromodulation platforms, Neurosphere Virtual Clinic. Go beyond your clinic walls and extend patient care. Give patients the flexibility and comfort of receiving care anywhere. Perform routine programming adjustments and device checks remotely. Neurosphere Digital Care is here. For you, for your patients.
So again, now that there are three, everyone is trying to distinguish themselves a little bit and offering different bells and whistles. The one that has been most established and the one that I was trained on in residency and fellowship, and the one that, just because they were the one that was around the most, that has been implanted is Medtronic. They are coming out with a directional lead. It's not available just yet, but what they have developed recently is their new battery that is a sensing battery. So this is an idea where if we can gather information based on a patient's clinical symptoms, let's say of tremor specifically, because that's the one that's easiest to visualize and think about, is there a way that we can track what's happening from a stimulation perspective if there's fluctuations in the symptoms during the day? If we could track that, could we then better modulate the type of stimulation that we have to do? Could we then adjust meds more effectively and appropriately? It really is a wealth of information. I'm not going to say it's not a little daunting to think about as the doc, and this is something that's more from my end than your end, but knowing that there is now the ability to have a device that is able to sense what is happening before symptoms change is the next step in being able to have reactive programming. So you don't have to then make the adjustments, but the device itself could react automatically for you. So it's also pretty exciting. I'll play the little video that they have from their website as well. But again, this is something that we'll talk about next week's a little bit more. again, if you are interested in learning a little bit more about the different devices, all of their websites are equipped with different videos and patient testimonials and things like that. Like I said, the nuts and bolts of each device is fairly similar. The reasons for getting DBS are the same across the board. Getting down to why you would choose one platform over another really has to do with certain things about patient preference, about the specific type of symptom you're really trying to mitigate and manage, the surgeon's preference, the neurologist's preference. There's a lot that goes into it, but all three provide excellent DBS therapies. So it's nice to have choices, even though sometimes it can feel a little overwhelming, but that's why you have us to talk to. So we'll finish up now. This is just a quick little thing. If you are interested in doing some advocacy this month, it's a pretty easy lift. So that's why I'm mentioning it. There is a campaign right now called Give a Dime About Parkinson's Disease. And what it is doing, it's a play on the March of Dimes that was done by Franklin Roosevelt in 1938. And you can go to this website, endingpd.org, and you can request these postcards to be sent to you, and then you can send them on. You don't have to do anything to it. If you wanted to write your own personal anecdote or explain why you think Parkinson's funding for research needs to be increased, or better medication coverage, whatever it might be, you can, and then send them off to your congressman, because they're looking to get 100,000 red letters sent by the end of the month. I've requested about 100 letters. So if you are one of my patients and you're coming to see me in the office, then you can always fill it out while you're here and we can send it off, or you can have a mail to your own home and do it yourself. And this is done through an international effort called the PD Avengers. So you might want to take a look at that as well. And it is a bunch of movement disorder specialists, four in particular, that have come together to provide resource and advocacy and access for Parkinson's awareness. So just something that in the since it's Parkinson's Awareness Month, you might want to get behind to try. And then I couldn't get past this talk without talking about vaccines. Hopefully most of you have them already, but if you don't and you've been having difficulty finding, it seems the one that has been most consistent for my patients has been the Atlantic Care site. So if you have the ability to drive down to Atlantic City, or if you're in that area as well, vaccination atlanticcare.org is seems to be a fairly easy, user-friendly site to use. And I was just on this morning making an appointment for my husband because he's now eligible to get it. And as you can see, they have lots of slots available. And they had a lot for today, so they must have gotten a random batch of vaccine in, but throughout the month they have considerable availability. So I just wanted to share this with you if you need it, or if some of your family members do. I know that it has been a little bit of a process, more than a little bit of a process, to try and get the vaccine. And if this can help, I just wanted to share and let you know. So that said, we are done. And I saw some questions come in, so let me see if I can get to those, and then I won't keep you much longer because we're just at 1 o'clock, and then we can always save them for the Q&As later in the day. And let's see. So the first question is, was this being recorded for viewing later? Yes, it is being recorded. It will either be on our website or our YouTube channel, and we'll send out the link once it's available for viewing. So do not worry about that. Can Sinemet or Requip cause ulcers? Not typically. They can cause GI upset though, but they don't typically cause a physical irritation to the gut. And the vivid dreams that some people have, it's called REM behavioral sleep disorder, and that is part of Parkinson's. And much like everything with Parkinson's, sometimes it's either from the disease or from the medications that we're using. So if it's not something that you have had, but you did start medicine like a dopamine agonist, or you're taking a higher dose of Sinemet at bedtime and then they occurred, it might be medication related. So you can talk to your doctor about adjusting those, either back or switching the timing in some way. Likewise, if you're not taking anything close to bedtime and you're having it, it could be because your levels of dopamine are low. So sometimes adding medicine just before bed can be helpful. If you are already taking medicine before bed, and this is something that's been going and coming on and off for some time, you don't think it's medication related, the medicines used to address REM behavioral sleep disorder directly is Klonopin, clonazepam, sometimes melatonin, but that's not always strong enough if the vivid dreams are very pronounced and the movements are very exaggerated. And then if Klonopin is not working, then looking at more potent medicines like Seroquel or Trazodone can sometimes be helpful. But that's sort of the hierarchy of how we address it. And is THC, which is a part of medical marijuana, used to alleviate any PD symptoms? And the short answer of this, because I did a whole presentation on medical marijuana and Parkinson's disease, the short answer of this is it can, but it's really focused on the non-motor symptoms. So the sleep disturbance, depression, anxiety, pain, things like that. We don't really look to medical marijuana to help with the movements, the tremors and slowness and stuff, unless more traditional strategies have failed. But looking at the non-motor things is where there seems to be more benefit, because for those non-motor things, even outside of Parkinson's disease, there is data to suggest that it's helpful for pain, for anxiety, for sleep, etc. Thank you, Mr. Gray, for saying it was a great session. And so here's a question about people with freezing episodes. So there's moments where there's gait freezing, and this is a great question. So gait freezing is hard. I'm not going to say that it's not. Treating freezing of gait is really difficult. It's difficult, especially if it happens not related to your medication. So your medicines are in your system and you still have freezing of gait. It's a little bit easier if you notice that this happens when the meds are wearing off of your system. So would an on-demand therapy like Kinmobi be helpful? The answer is possibly. This is a longer question, and we could address it at a visit, but the short answer is possibly. If the freezing episodes are long enough, where it's not just episodic, where you are walking and all of a sudden you stumble and freeze, and then you stop, you think to yourself, okay, take a step like you were taught in big therapy, march in place, or touch your leg, or do something to get you moving again, then something like Kinmobi might be helpful, because if it's long enough, it's going to take a little bit of time for it to kick in. If the episodes are short and brief and you can self-correct with behavior, an on-demand therapy might not work because it simply won't work fast enough. But yes, getting back to walk as much as you can, physical exercise and activity is so important. So let's see, I think that was it for those questions. And I think there was some in the Q&A. Let's see. Is there a way to do this as a Facebook fundraiser? I'm not sure what this you're referring to, but so I can't say yes or no. I'm sorry. I don't see any other questions coming through. I'll check one more. Oh, the postcards. Okay. So I don't think so, because that is done through, like I said, the Parkinson's Avengers. So if you did have questions about fundraising for different local support groups or whatever it might be, I would speak to it through the endparkinsons.org site and talk to them about it, because they're the ones that are running it. I was just sharing it because I found it to be a fun advocacy thing to consider to do. And with that, Frank Costas has raised a hand. Do you have a question, Mr. Costas, before we sign off? So I did just want to say thank you so much. Again, if you had questions that you didn't get a chance to type in today, or it was just a lot of information and you haven't processed it all yet, you can send the questions to the movement@gnineuro.org, and you'll get reminders for the upcoming sessions over the next few weeks. So if you haven't registered for them already, please consider doing so. And if you were unable to attend today, or know people who were, then by all means, please check back for, we'll send the link out when the recording sessions are posted for you guys to view on demand. And I hope you found this helpful and informative. And I really do appreciate you taking the time to listen. And for all those who are celebrating, I wish you all a happy Passover and a happy Easter. And I'll see you next week. Okay, bye-bye.